Hi, I'm Arlen Meyers. I'm with the Society of Physician Entrepreneurs in MI10, and we have a bunch of other folks that may look familiar. Our guest today is Brandon Aylward. Brandon, could you take a moment and introduce yourself and tell us a little bit about what you're doing?
Yep. So I'm Brandon Aylward. I'm a clinical child psychologist by training. Spent a number of years working in academic medicine across various children's hospitals, developing digital health tools for support and assessment of chronic illness conditions outside the clinic area. And then I moved outside of academia, worked in industry for a while, working with various digital health startups, including Cognoa with Sharief, and then worked for a large consulting research institute called RTI International, directing their digital health research and evaluation efforts. And then have, for the last 4 years, have been doing my own consulting under the umbrella called PedsTech. So primarily with companies in the pediatric behavioral health space, kind of a wide variety of things from business development to grant writing and research dissemination to implementation of digital health tools into practice. But I also work with outside the pediatric space as well into some adult based health startups as well.
And where are you based?
I'm in North Georgia mountains. It's about 2 hours outside of Atlanta.
Okay. So tell us a little bit about your background. I mean, why did you, of all the things you could have been involved with, why this? What's the why?
I think the why is that I started in academia, really worked to develop digital health tools. A lot of that time was spent grant to grant to develop these tools and to have an impact on children's health. And then I moved outside of the industry. I did a number of entrepreneurial courses while in academia, and I was just interested in how you can take these types of solutions to scale. So I spent a number of years in industry and kind of really was passionate about building things from the ground up and having a large impact in children's health. And then kind of moved a little bit more on the strategy side of things, taking that large lens of now that these tools have been validated, how do you implement them into practice? How do you really move the needle in children's health? And have really enjoyed doing that over the last several years.
Good. So just a little couple some ground rules. If anybody has a question or they just want to ask something, put it in the chat or raise your hand or do something and we'll address it. So Brandon, tell us a little bit about the status of pediatric behavioral health and why is that important now?
I'd say taking a look at the overall behavioral health, not just in pediatrics, but what we see over the last 5 years, 6 years, is that behavioral health has been the most highly invested area in the digital health space. Based off a recent Rock Health report, it showed over the last 5 years. What we see is about $1.4 billion going into mental health and behavioral health space. But broadly, what we see is in the AI space, and that accounted for about 36% of funding in digital health over the last year. So I think they were at about 10.1 billion investments in digital health over the last year, and about 3.2 billion of that was within the AI space and 1.4 in the mental health and behavioral health space.
So it's a big problem, both adult and pediatric. And what are the trends that you're seeing? Let's focus a little bit on the pediatric side. And Sharief, you're certainly encouraged to chime in with this. What are you seeing now? Because, it was pre-COVID, COVID, now we're sort of into the post-COVID, and now we're into the post-COVID AI. So when you kind of go through those sequences, what trends or things are you seeing?
During the COVID era, both in pediatric and adult mental health and behavioral health, what you're seeing is kind of a quick adoption of these digital health tools and kind of this step care approach where you were having addressing subclinical issues. So you had coaching, you had psychiatry, you had psychologists involved, and really trying to help navigate and provide support to a large mass of people. And so I think there's a quick pushed to adopt these solutions during that period. And then there's kind of the shift to say, now that we've adopted, what is their effectiveness? What are they doing from a return on investment standpoint? And there's much more of these types of solutions.
So to that point, what is the ROI? Do these things work?
You're seeing more publications come out in that area. So a lot of companies are doing some of those cost effectiveness analyses, and they've been published, I'd say probably over the last 12 to 18 months. You're seeing more of those kind of publications come out, some of them showing that return on investment from healthcare utilization to kind of prevention of long-term impact. So really in the adolescent space, you're really trying to address these issues early so that they don't persist into adulthood, and really see the cost savings there.
So the answer to the question is, I mean, do they work? And if so, what, when, and how? And by work, I mean, do they actually make the patient better?
Some of the models have shown to show that cost savings from healthcare utilization, inpatient stays, and so forth. All of them kind of have different models, but I think the importance is that this kind of comprehensive care model, that it's not in isolation, that there's care coordination from, for example, with the primary care physician, the pediatrician, bringing in other kind of supports to connect these individuals to community resources. You're seeing a big effect on those that with subclinical issues who might benefit from health coaching and might not need escalation to psychologists, which free up some time and opportunities for them to get that increased level of care.
Right. Sharief, you've been down this road. And why don't you just briefly tell people about your journey? And my question is, what were the significant barriers, or are the significant barriers you need to overcome to deploy an integrated?
Well, Arlen froze, I think so. Or is it me?
I think he froze.
Oh, okay.
Right.
No, I was gonna chime in when you were talking to Brandon about the efficacy of these things. I actually think that that's the least of the issue. For the most part, if the devices have gone through, well, let me rephrase that. There is a regulatory step to try and prove safety and efficacy through the FDA, right? So a lot of these things did have good evidence to show that, hey, if I deploy this, activity, it's going to improve your ADHD. Or if I, use this device, it's going to help me diagnose the thing that I'm trying to diagnose. I think there's kind of two areas that, one where Brandon actually was very helpful in Cognoa. So we actually did a really good scoping review on a lot of the inequities, disparities, challenges of getting a diagnosis for certain communities. And that article actually ended up becoming a foundational article for board certification for child neurologists. So it's actually in the queue of like things you have to read and answer questions on to maintain your maintenance of certification for child neurology. So I think that those things of thinking about like return on investment, do they work? It's yes, there's clinical evidence, but there's also these access issues. And I think this is the fundamental area where Brandon, maybe you can highlight, but we just don't have enough clinical psychologists. We don't have enough pediatric psychiatrists. We don't have enough. And I think it's not just in behavioral health, right? Like that's across the board in healthcare. And so it's figuring out how do you get the technology then implemented in a way. And I think the biggest challenges are one, not in this order, but workflow is one big one. How do you integrate with these systems, et cetera? And then the second one is actually, how do you get them paid for, right? Because if you have a suite of 100 or 1,500 digital tools and you're expecting the clinicians to pay for every one, the clinicians are going to be like, I can't do that, right? So, and the environment, I think, is not mature enough yet to figure out how they pay for those. So I'd love to kind of maybe hear, Brandon, your thoughts and maybe others. How do you get through that, I don't know, cost hurdle, if you will, of, hey, we've got a great tool, it actually works, but the insurances maybe are reticent to pay for it, don't have structures to pay for it, don't know how to pay for it, et cetera.
I think
Okay,
there's,
so you've highlighted workflow, AI integration, and reimbursement. Brandon, do you have any comments about what you're seeing in that? Now there's this big conversation about whether telemedicine, just writ large, will be covered by Medicare, given the changing administration and CMS, debt, and all that other stuff. So, what are you seeing, or how are you thinking about this?
well, what you saw is, there's that quick adoption. And so basically people were forced to implement these tools into existing clinical workflows. And then there's this kind of period where there's increased scrutiny to show that these products actually work. And then that, even if they show they've done the trials, they show that they work, they gather real world evidence, then you have the hurdle of getting providers to adopt these solutions, because it's going to be some kind of change in workflows. So things like taking from process improvement science or implementation science, there's kind of techniques to really support and the adoption of these digital tools into practice. But you really need those project champions or those provider champions to help spearhead how these are going to fit into existing clinical workflows. And it's going to take some time from some of the frontline providers to administration and so forth to adopt these tools. Because even if the purchasers or the big people that make decisions at a hospital say that providers should use these tools, it doesn't necessarily mean that it'll just easily be integrated into practice. And so you'll face some resistance, and there needs to be that culture of adoption.
Right. Harvey, this gets down to the issue of the barriers to adoption, dissemination, implementation. Generally, whatever technology, but in this conversation, it's about pediatric behavioral health platforms. And the observation has been made that the primary barrier to adoption is trust in artificial intelligence. So the question then becomes, well, how do you get people, and in this case, the people are pediatric practitioners and other healthcare professionals, to use it? And so this gets down to, Harvey, maybe are there lessons to be learned from large language model adoption that translate to other technology adoption? Why did people use certain, and I don't want to get too deep in the weeds with DeepSeek, because that's kind of the topic du jour, and I don't want to get too far into that, but what, just generally, how do you get somebody on the front lines to use this stuff?
Simple things is, and I know you guys can attest to this. Number one, if you're designing, you need to have the practitioner or the healthcare professional in the loop, because, I'm in the front lines and you give me some widget that I don't agree with, or that was a problem that shouldn't have been solved, or the way it's being solved isn't the way I think it should be solved. So having that in the loop is number one. Number two is transparency. Having everyone on this call be part of the C-suite or influence or part of those board meetings, so that when they are looking at these devices that maybe they were already created without you in the loop per se, that helps in adapting. And obviously the last is transparency. Us doctors enjoy seeing pictures, and I say that loosely because I've yet to meet a doctor that I don't show them a mind map or some image that they're like, oh, wow, I get it. And so showing like a graph GPT of how it got to that decision process. So if I say A goes to B equals C, show you how that graph, and then that allows that. And then that ultimately all can be summed up with changing the culture.
Okay. To go back to Brandon, so can you give us an example of a specific application for a specific intended use to solve a specific problem, and how that played out, good or bad, success or not success, or partial? Can you kind of walk us through a use case?
I think one of the use cases is during my time at Cognoa, we were really looking to see how pediatricians would adopt their digital diagnostic aid, after it had FDA authorization. And so really working to understand, how does it fit within practice? How does it, there's kind of two things. One is provider adoption, and things that influence that is the payment. How long is it going to take to get reimbursed? How are they going to write scripts for it? And with a lot of these tools, you have to figure out how they're fitting in the workflow. Does it take additional steps outside the EHR, for example, for them to log into a portal to enter some kind of information that then is fed back? And Harvey mentioned some important things, is understanding how that arrives at a decision. You know, there's this trust around it. If it's a black box and you don't understand how it arrives at a certain decision, then there'll be less likely to be trust in the system. So one of the things that we did is we did a lot of quality improvement studies, and I know Cognoa has continued to do those with some kind of hub and spoke models to increase adoption of tools. And I'm sure Sharief can speak a little bit more towards that.
Yeah, I was going to actually add in, Brandon, one of the kind of I would say foundation planting seeds that Brandon also worked on was thinking about like specialty societies. And I think that that's actually really important. So if you're developing, you know, for example, a tool in the dermatological space, the last thing you want to do is have, you know, whatever the Academy of Dermatologists is like, start saying like, oh, this is garbage, we don't want you to use it. And so a lot of the work that we did was, you know, to connect with, let's say, Society for Developmental Behavioral Pediatrics and try and help their leadership understand, what were we trying to do? We're not trying to replace the doctors. We're trying to help you as clinicians, right? American Academy of Pediatrics actually updated their guidelines to include Cognoa's Canvas DX within the guidelines. And actually, there was a mention in the last national meeting in one of the keynote addresses. So it's a lot of that foundational work when you're developing these tools. It's not like, hey, I made the cool widget and suddenly everybody's going to just start adopting it. Like, that's not reality. You have to actually plant the seeds and do the hard work and show the evidence to actually get into the in front of the specialty society leadership and let them understand, like, hey, you're not, this is not a physician replacement. This should not be viewed as a threat. This is something that we've designed and created to actually help you in your clinical practice. And I think that drives a lot of goodwill, if you will, within the organizations, within healthcare, et cetera.
So you bring up a couple points, and one of them that I want you to drill down on is many of these platforms are developed by techies. They're not, I mean, they may have some familiarity with healthcare, but that's usually like a brother-in-law who's an orthopedic surgeon. And they really don't understand the ecosystem. They don't understand how complex it is. So my question is, for those that are, I mean, we've heard over and over and over again, it's the reason why you should get healthcare professionals engaged in the process early on, so that you can be acquainted with, even if it's superficially, what's going on in healthcare and how it works, the business of medicine. But what you bring up is there are a couple of things that startup founders it's an afterthought. In other words, to your point, how do you get approval from a stakeholder specialty society? And what does that look like? Secondly, how do you get a CPT code if you don't have a CPT code? Third, how do you get somebody to pay for it like CMS? So let's just back up a minute. Just walk us through how you got the attention of, let's say, the American Academy of Pediatrics or subspecialty societies. How did you actually get them to say your thing is not garbage?
But I think that that's the point that we were making, right, Arlen? And you hit on it, which is really important, which is if you're making these in a vacuum with technology only, and you have no clinical real leadership within the organizations, and you don't have clinicians engaged within the organization, the tech organization that's building the technology, then you're not going to win. And it's not even just, you know, no offense to anybody who actually didn't practice medicine, but there's a difference between getting an MD degree and actually practicing medicine. And I think those are very different. So having people that have actually been in the trenches, understand how things actually operate and work, I think is very important. And it's a guiding principle, whether you bring them in as an advisor, whether you bring them as a chief medical officer, whether you build them in the part of your medical affairs team, you have to have those people within that tech organization. And if I see a tech organization that doesn't have real good leadership within that space, then it's probably not going to be successful. I just don't see it happening.
I agree.
Hansa, yeah, I'm sorry, Susan, were you going to say something?
I said I agree with Sharief totally. I mean, you have to have people in the organization that are very well versed in the clinical aspects of behavioral health or pediatric health. I've been working with general pediatrics for quite a while, and I also agree with him that organizations like the AAP should really be out there supporting and pushing our efforts as pediatricians to support programs in behavioral health and diagnosing autism or other behavioral health issues. And I know that there's guidelines, you have to have validation in certain studies. I understand that. But as pediatricians, we all follow, I believe, all the aspects that we've been taught over the years. We go to our meetings and we study what they publish, etc. So Sharief is absolutely correct in that.
Can you give some examples of how you do that? I mean, we keep saying you need to do it, you need to do it. What I'm trying to get is give us some concrete steps on how you do this. Is it you're a member of your specialty society, you give a course at the meeting, you show, I mean, what are some things that you can do to socialize the idea and get buy-in and support from your cohort, from your specialty cohort?
Are you asking me?
Yeah, well, anybody. Yeah, sure.
Oh.
I mean, if you want to chime in.
So I think one of the things we did at Cognoa is within the medical affairs team is we try to identify key opinion leaders, so people that are, have strong expertise in the field, and through publications, through academic appointments, through appointments on societies, and did outreach with them. Not only that, not all those led to meetings, but kind of start to, in a sense, do customer discovery interviews to a degree where you're trying to get feedback on your product. You're trying to get the word out there on your product, and then start to then build out more conversations. And sometimes those lead to people that are decision makers within some of these societies, and it increases their awareness. It gets them on the radar, which then that can inform some of their guidelines or other things like Sharief mentioned, where Cognoa was mentioned by AAP, and it helped change some of the guidelines too.
Yeah, I mean,
So this is Jennifer.
Awareness is huge. Oh, go ahead, Jennifer.
So this is Jennifer. I'm on the board of one of our specialty societies. So how it actually works is most of the societies, if they're not doing it now, they're starting to do it, are setting up innovation centers. They understand that a lot of physicians need additional technology, but we aren't going to vet it. So the way it typically gets vetted in our world is that it goes through an innovation program, accelerator program. We have industry there, we have VCs there, and we get the opinions back. And so the ones that move forward and actually have great clinical data, we start discussing. We're never going to support any type of technology. I mean, technology, I'm actually like a product, but we will actually allow the platform for the innovation or the new product to be seen over a wider area. And this usually happens around the time of a national meeting.
Jennifer, why wouldn't you support it? If a product is, just to tell the devil's advocate, if a product is you feel, that is you, the society feel it is best in class and crosses all the T's and dots all the I's, why not support it?
Yeah, I mean, we support vaccines.
So vaccines are a general vaccination, right? With data. We're going to support technology, but not a particular product. And so in most of the bylaws of these societies, it's very clear of what stance we're going to take and how we're going to support. And so the decisions were made to support it by giving it visibility and access to either our industry partners or our members.
Okay, so I'm going to give you a different perspective.
Hang on, Arlen. Sort of true, right? But if there's only one of them, right? So if there's only one RSV vaccine, we're going to support the RSV vaccine. That happens to be the only one. So yeah, you're not going to call it by name Synergis synergist, but you're going to say, hey, we recommend RSV vaccination for these little kids who are going to get, not going to survive if they don't get synergist,
Right.
Correct. And it'll be part of
Peter,
the clinical guidelines that vaccination for RSV is recommended. We're going to say it's grade A, but we're not going to say the one brand just in case there's another brand that comes out that also has the same clinical data.
Peter, did you have something you wanted to say?
No, it's okay. Yeah, Sharief beat me to it, so that's fine.
Okay, so I just wanted to present another perspective, and that is, for example, the American College of Cardiology and other specialty societies have venture funds. Now, that's a relatively new thing because, like most specialty societies, I get it, they're not for profit. We all have our own little club, and it's mostly an education and research foundation. But they have created dotted line or affiliated for-profit entities. And those for-profit entities are specifically designed to incubate or accelerate technologies that they feel are useful to the specialty. Cardiology does it, gastroenterology does it, I believe rheumatology does it, and actually I was involved with doing it with the American Academy of Otolaryngology. So the landscape has changed, and therefore the platforms for further developing and adopting and integrating these technologies has changed. So I'm not saying it's the right or the wrong thing to do. I'm just pointing out that things have changed and that there are opportunities, and particularly from the perspective of this audience that is trying to get an artificial intelligence or problem, and they're trying to figure out every single way they can do that so they can get it to a patient. I just think you have to be a little bit more flexible in terms of how you do that. Now, that's not easy, because now you got to convince the board of the American Academy of Pediatrics, gee, maybe we should do this. And we all know that's not an easy lift for any specialty society. So I'm just pointing out, though, that keep your eyes out for what's going on. Stephen, you represent, as if I'm not mistaken, the nurse practitioner group and leadership in nurse practitioners. So how does all this fit in the nurse practice, primary care, physician, scope of practice, et cetera, landscape?
Thanks, Dr. Meyers. I think there's a lot of overlap, in the primary care space, since the majority of nurse practitioners largely do primary care. So the ambient, scribes and all that, that's kind of like the most adoption and uptake right now. There's not a lot on the nursing documentation side, like the RN bedside traditional role of a nurse. There's only a handful of companies, if that are there. But I think a lot of this conversation overlaps with the nursing profession. There is largely not nurses involved in the development of the technology, whereas some companies may have a non-practicing physician. There's no nursing represented at all. So I think it's imperative, that there is the representation there. There have been some fairly large surveys. You might have seen these headlines through the American Nurses Foundation. 7,000 nurses were surveyed about AI in particular, and there's an overwhelming positive perception of AI, but only when we understand what it's suggesting and how it got to that suggestion. So, I think with burnout and administrative burdens that encompass all of our workflows, we are desperately looking for solutions that will help to eliminate some of that, put back some of the joy in healthcare. And I'm borrowing that from some talks that I've listened to about AI in healthcare. So I think largely it overlaps, and we need to be there at the table. And where's the table and how do we get there? And I think I'm happy to participate in these. And, with AANP, the American Association of Nurse Practitioners, we're happy to help facilitate some of these conversations as well.
I'll say,
so why don't you do what? I'm sorry. Go ahead, Sharief.
Sorry, I was just gonna say if you all have digital health, AI-based solutions, and you're not engaging nursing, you're missing out 100%. And to be honest with you, actually, some of our fiercest and most kind of successful advocates of actually getting adoption through have been nurse practitioners in places. They're uniquely positioned to figure out how to actually do stuff in the hospital. Versus a physician champion. They're like, this is great, but then they don't know how to actually operationalize it. So definitely look for the nurse practitioner champions. They're also, I don't know, there's something about the way that I think that we have some little bit of training differences in which I think NPs are more maybe willing to try new things. I mean, think about it. If you're at if you come from bedside nursing, you're hacking all the time. You're always figuring out, how do I duct tape this thing together because nobody made it for me. And actually, some of the best innovation ideas come out of nursing. So maybe to Jennifer's sort of comments about these innovation arms that we're creating at the Children's Hospital where I'm on medical staff, some of our best ideas come from bedside nursing, from nurse practitioners, because they're uniquely seeing the problems. And I think encouraging that culture of innovation within healthcare institutions, you don't actually have to figure out how to fix it, but you can sometimes bring the best problems forward, and then the innovation team can work with that nurse or that nurse practitioner to actually build the solution. Mm-hmm. And then maybe the last thing I'll just add in, and I'm sorry I'm being a little bit long-winded, this concept of multidisciplinary development, I think, is critical. So I think what you were hearing from Brandon, but maybe we need to click in it a little bit more. It wasn't when we were developing Canvas DX for the diagnosis of autism, we are including all kinds of people within the healthcare environment, but also engaging with families, with parents, with people who are on the spectrum, with a diverse group of, we engage the Color of Autism to come review our product to make sure we were culturally sensitive and we weren't building a tool that was going to, propagate some of the racist bias stuff that was already in the status quo. So you have to do the diligence, because then when you go to market, you can say, because we get asked all the time, well, did you involve people who are neurodivergent in the development? And I can say, absolutely. In fact, our entire beta testing team is all individuals who are on autism spectrum neurodivergence, right? So that kind of stuff is really important.
So Stephen, I'm sorry, go ahead, Brandon.
I was going to take a step back at kind of a 10,000-foot view as we talk about these new solutions, these new widgets. And one of the things kind of Sharief mentioned, and it relates to innovation, is there authentic demand for it? And there's a book out there called The Heart of Innovation. And, everybody comes up with a value proposition for their new solution for healthcare. That's going to save money, it's going to save time, or so forth. But just because we have this view that that's the problem, if we haven't done the interviews with some of those nurses, with physicians, with administrators to really understand what is the pain point, and we just go out there and develop a solution, it doesn't mean people are going to use it. And really has to get at the heart of the innovation and say, are people, are the people indifferent to it or non-indifferent to it? And if you're non-indifferent to it, that means it's going to really change and address one of those pain points. And so I think that's going to lead to something that can be more readily adopted than just developing a thinking people need this, and they haven't done the customer discovery interviews. They haven't really gone through what is the true value proposition of this tool.
So Stephen, to go back to this point, most people on this call agree that interdisciplinary and interprofessional collaboration is a good idea. I don't care whether it's nurses, dentists, pharmacists, you name it, anybody in a white coat, whatever. But the issue really is that for so long, we have been so siloed and basically don't play nice together. In fact, we are antagonistic. And I don't need to go through the scope of practice conversation as the discussion. So let's just put that aside. Let's just say we're here to try to figure out how to play nice together. So how do we do that? What is the single most important thing? For example, the Society of Physician Entrepreneurs is an open network. Now, you might say, well, why is it called the Society of Physician? That's another story. But the fact of the matter is it's an open network. Anybody can join. I've been advocating for interprofessional entrepreneurship for a very long time. There are our nurse organizations or entre-nurses or whatever, portmanteau you want to use. So how do we overcome, what can we do to solve this problem when it comes to nurse practitioners?
Yeah. And this is something that comes up often as president of AANP. You all might have seen Bloomberg wrote a series of articles that sort of denigrated the profession and the education. I think, there are some challenges within our educational system, but being involved with this group, there's challenges within the medical education system too. So I think we need to acknowledge that no system is perfect. I think we want to be very cognizant of, AI not taking over, and that perception of physicians saying to nurse practitioners, oh, see, you need to use these AI tools because you don't know any better. And I'm sure physician community is saying that too, right? So I think we're saying the same things. And I think has to be a mutual understanding and respect of the education and the preparation that we go through. NPs don't go to medical school, right? Our schooling is different. What we do is very similar to that of physicians, but it's not the same. And I think it's having these types of conversations. I never went to medical school. I went to NP school, and I would venture the physicians here didn't go to NP school or dental school or whatever. So I think there has to be a mutual understanding and respect of our backgrounds. They're different. And I do hope, and maybe call me naive, that technology will be that thing that ties us together and overcomes these turf battles and these, ridiculous energy and resources that we spend doing that. So.
Okay, so I don't want to beat this to death, but maybe you and I can take this offline and figure out a way to take one step we can do to create this issue of interprofessional collaboration, particularly as it results in health IT and AI. Peter?
Yeah, I was just thinking on the thing that I'm probably about to state the bleeding obvious, but I'm thinking about trying it somewhere, even if it's just, and I know it's very, very sort of small things. So you get your live case studies, and like I say, it's probably saying the blinding obvious, but then by doing it and demonstrating the outcomes and the improvements for the patient, patient in particular, but also for the professionals, and then probably from a productivity point of view. There's 3 Ps in there. It may be something like that. It could be very small scale.
So Peter,
PDSA cycle thing, couldn't it?
Peter, people may not know that you've had a background in working in the National Health Service. My question is, whether it's the NHS Innovation Service or the Entrepreneurship Clinical Program or et cetera, is the landscape any different in the UK, doctors working with nurses, than it is here?
I'd say it's sort of similar. There's this sort of hierarchical, and I'd throw in there what we call AHPs, allied health professionals, as well. There is this almost like this hierarchy, which people sort of do work together, but only within the boundaries of what their responsibilities are. And I think they don't necessarily work as teams. Teams, with my experience, they always, the whole is greater than the sum of its parts. So it's a similar problem over here. And I think, and you throw into the mix the sort of downward pressure there is on people because of waiting lists and all of those sorts of things. But maybe people are too busy to do improvement. It'd be no different. So I think it's all about people and leadership, and people being a team being willing to have a go at something that's different, because they've got a big problem they can't solve. So the only way out of it is doing something different.
Yeah. Brandon, you wanted to make a comment about the psychology of all this?
Yeah, throughout my training, the field of pediatric psychology has always been kind of multidisciplinary. And so in that, and as I've worked a number of years in working with different digital health products, it's really taken that multidisciplinary approach. So working with nurses, working with physicians, working with programmers, designers, marketers, regulatory specialists, and so forth, to really drive these digital health tools into practice. And there's obviously a psychology behind it and behavior change. And so having psychologists is an important, people with specialties in adherence or behavior change or, thinking about design thinking and so forth. These are important people to also have at the table, in addition to nurse practitioners and physicians and nurses that are at the front line.
Shri, did you have some comments you wanted to make? You've been putting some stuff in the chat.
Thank you, Arlen. No, nothing in general. Agree with most of the viewpoints. These problems are not new and have been around forever. And so AI is actually going to either bring us all together or maybe even potentially exacerbate some of these problems. So time will tell, but it makes sense, as I mentioned in the chat, to first recognize the limits of our knowledge and our own limitations. And so from that recognition will stem a couple of other things, be transparent about it. And then obviously in the AI world, there's a need for a multidisciplinary team. You cannot do it yourself. And so kind of understanding that and taking as I mentioned, a strategic, balanced, fair and ethical approach, I think is very important and critical for any venture in either the innovation or implementation domains to remotely even have a chance of success.
Hey, Arlen, in our last 15 minutes, you want to get spicy?
Do I want to get who?
Spicy.
Yeah.
So I'd love to hear what people think is going to happen over the next 4 years with some of the administration change. I mean, I think we've all seen this past week, right? A lot of changes on the federal government side, unwinding of some AI regulatory stuff that came in the Biden administration. There's a halt on all grants going out from the NIH. There's a halt on communication. I mean, I'd love to hear what people think, reduce regulations, which might drive innovation, but also sort of like no guardrails / significantly decreased, I think, funding towards innovation potentially. So like, it's a kind of like I don't know which way the scales are going to tip, but I'd love to kind of maybe hear what people think in terms of how do we think this may or may not play out? And I know it's all speculation, or if people are hearing anything from sort of the inside the federal government right now or federal agencies.
I think, who knows, but my guess is we've already seen unleashing, you mentioned it, unleashing regulation. I'm not sure whether that's a good news, bad news story, but my guess is it's probably going to be more bad news than good. Most of us are kind of looking at unfettered capitalism as creating a lot of problems. I think most people need some kind of regulation. I don't know what that looks like, but not regulating at all, I don't think is a smart option. The second is that the history of technology and almost every technological revolution has actually made inequity worse. And my guess is that it already is doing that with artificial intelligence and will continue to do so. I don't think there's a coordinated vision for the direction of the country in terms of where artificial intelligence should go, other than the threat of what I call the AI industrial complex. And most of that, I think, is being directed toward the Defense Department and how most of this is being driven by using artificial intelligence to win wars and to do war planning. Now, with the recent hullabaloo about the Department of Defense and who's going to lead it and who shouldn't, and the qualifications, it's a little creepy, but I think that's a significant issue. And that brings up the issue and the stress test. I happen to believe that the institutions that we have do that, but you never know. So all of this comes down to, okay, if you're an AI startup and you're doing the SWOT analysis and you're looking at the landscape and you're trying to figure out, well, how do I see around corners so I can get my idea to patients? What does that mean? I think that's the core question. Like, we're always faced with this landscape issue. If you're a startup and, what about money? What about regulation? What about changes? What about et cetera, et cetera, et cetera? So I'm more interested in what people, and I mean, my view is create the future, don't waste time trying to predict it. But if you're going to create it, you have to take into account the landscape and the barriers that you're going to see and whether they're threats or opportunities. So I guess I would rephrase the question for an AI startup, whether it's in pediatric behavioral health or something else, where are the threats and opportunities and how do you negotiate them? So what are you seeing from Cognoa, for example? Like, you have to be forward thinking. How are you positioning the company?
That's why I'm asking the question, so I can get some data points, Arlen, so I can steer the ship. I want to know what other people know.
Right. Well, it gets down to fundraising. I mean, there's a million different things.
But for sure. But I think, directionally, right? Like, I think understanding like what are the trends that are going to come up in this year. So to your point of like opportunities versus threats, right? So opportunities. Okay, well, there's a little bit of loosening of the guardrails on regulation. Is there a way to take advantage of that and still do it within obviously the lens of understanding like, hey, we are trying to get rid of disparities and we are trying to get rid of things, right? There's investment potentially on the tech stack side with, signaling from the federal government, like, hey, US wants to be a leader in artificial intelligence. But I wonder again, like, if you look at what that $500 billion project that's going to be, right? That's the Stargate or whatever they're calling it, right? To your point, it's probably going to be more defense and it's probably not going to help small startups. That's going to help the Oracles of the world, which is, not useful necessarily. So I think it's an interesting kind of ecosystem. Obviously, we're gonna have to see how it plays out. I think we're all gonna just kind of keep marching forward, obviously. But with that said, I think you have to know where you're marching to, and you may need to do some course correction. I think it's going to be interesting how that plays out.
Okay, so my 3 tips are the riches are in the niches. In other words, I believe that when it comes to artificial intelligence, what you need to aggregate and disseminate and scale it is so big that only a handful of companies are basically going to dominate the industry. And we're already seeing that. But that does not discount the fact that startups, and this Chinese thing is a good example, can disrupt the whole industry and make people crazy. So it really depends on playing the niches. And protecting AI intellectual property is almost impossible. People are saying you have to use trade secrets because you copyright or patent it or whatever. But the point is, if you're really good, and all these people are, you can reverse engineer the platform and just build another one. So it's a million Me Too LLMs. So how do you differentiate yourself one from the other? And it really comes down to the non-AI aspects. Relationships, networks, people, this stuff that we're talking about integrating this, for example, into a professional society to get backup, to get support. So that's number 1. Number 2, I think having just heard what I heard in the last couple of weeks, that raising money for startups will get harder. So you really have to do more due diligence and get to this issue of understand the problem rather than the solution, and really be clear about how you are different and what it is, what problem you're trying to solve and how to get that money. And that gets to the issue of what kind of money. So are we talking pre-seed, seed, angel funds, whatever? You have to be a lot more specific about where there's the right money fit. And I would also say that very, very few IPOs are happening. So if you think you're going to build this company and scale it and do an IPO, that's not going to happen. I don't think it's going to happen in the next year. But most of the financial transactions and the exits are in mergers and acquisitions. So a lot of people are positioning, they're built to sell to some acquirer, whether it's pharma or biotech or med tech or AI or whatever. So I think you have to come into this with eyes open and adjust the strategy. Hansa, do you have a question?
No, sorry.
No?
No question.
Actually, can I?
You're a pediatrician and you're doing other stuff. So give us your headline impression of what you've heard so far.
Yeah, no, I think I agree with you, Arlen. I think differentiation is really, really important. And to Sharief's point, and other points that were made, I think, adoption of the technology is superbly important, whether it's, getting the healthcare system or doctors involved in development of tools and get engaged, or is there a strategy to, like a lot of the telehealth platforms, go to employers? There's, I think it all boils down to differentiation and workflow integration and adoption of the technology. And that's what I struggle with when I see all this money being poured into AI and wonder, well, at the end of the day, as a physician, as a pediatrician, like, how is this going to make a difference to the families? How is this going to make a difference to the doctors? I mean, I think probably a really good example out there right now in terms of making a difference to physicians is like a bridge. Are these technologies with a transcription, and what do they do differently that got them so quickly adopted? And I think one of the things they did differently, in my humble opinion, is that they got health systems very engaged very quickly in the development of the tools. And I think so, either you, Arlen, or Sharief or Brandon mentioned that, having the health systems and the professional societies and networks being involved is super important for the success of a tool.
Ellen, did you have a question or a comment? Did you have your hand up?
No, I was just going to answer Sharief's question about what I thought was going to happen with the shift in the regulations. I do think that, state regulations are going to increase. Each individual state's going to come up with their own AI regulations. And it's going to be harder, like you said, for startups to enter the space because they're going to have to manage all of the different state regulations. And health systems are going to have to govern all of these new tools. And the health systems, like community health systems that are small, are not going to have the talent pool and data scientists to be able to vet these tools properly, which means that they're going to be left behind in being able to purchase or look at these tools. So in response to that, there's going to be a lot of tools that are going to be made more for consumers because the barrier to entry is going to be easier. But
Helen, a really good tool to kind of think about this like onslaught of consumer-driven technologies. Sabrina Braham has been working on a project called Willio Health to try and curate and help clinicians understand like what's good, what's not good. I don't know, Hansa, you're also like really big in this space. Are there other ones other than Willio that you can think of?
I mean, I think the PEDS Marketplace.
Yeah, that's a great one too. How about non-PEDS related? PEDS Marketplace for sure is great.
I don't know any offhand except Daniel Kraft's health.io, where he's trying to put together that directory. But to your, like, that's an interesting point, right? Like, how do you vet these tools? And to be honest, like, even if you go consumer, direct to consumer, like, everyone's tapping at these big employer doors, and they're exhausted from it. I think there's a lot of exhaustion from all these tools coming at them. So, I think that an important niche, Arlen, as you said, would be, in vetting these tools and, making sure that there's some easy way to do that. In fact, it's so interesting because I remember talking to one of the docs over at CHOA recently, maybe it was a year ago actually, and he was in mental health, and just interesting because we're having this discussion. One of the questions he asked is like, do you know any place that actually vets these mental health tools? Like, they're coming out of my ears. I mean, I'm being approached by so many vendors, and I don't really know how I'm supposed to figure this out. But it's not just like in terms of equity and effectiveness, but it's also how easily they integrate and what's and the cost from the hospital system's point of view. I mean, Sharief, what do you think about that? I mean, what are the parameters that makes a tool easily integrated?
No, that's why I
You're
hired
absolutely
you
right.
today to help me at Cognoa, right?
Yeah, you're absolutely right. The integration into the workflows is key. Like, how well do they integrate into the EHR? Because if they don't integrate into the EHR or even into the patient portals that patients are utilizing now, health systems aren't going to want to use them.
But on the flip side of that too, Helen, like, you're an informaticist, so too, like, integrating some of these things turns into a nightmare. And sometimes when you're trying to like evaluate, like, hey, does this thing actually work? Sometimes actually having it not plug into the EMR may be a good sort of first step. Let's get it in the hands of clinicians. Let's have them trial it first. And then if we're like, okay, we really want to adopt this, then do the heavy lift of the EMR integration. Because a lot of times we end up integrating stuff in the EMR and then we're like, nobody's using this stupid thing.
Yeah.
Right? We did all this work to get the APIs going, and you're like, oh my God, why did we do that? So anyways, but yeah.
The other question I have, Sharief, like, this is a question for you because you have Cognoa. I mean, if you look at the example of Otsuka, right? Like, basically integrating, having a partnership with a big pharma, to kind of get things down. Like, I'm just thinking about, like, every time I hear anyone talk about exciting AI stuff, my question always is like, okay, that's great, but how do we actually get this adopted? And so, like,
I wonder though, Hansa, like, I think you hit an interesting point, right? These partnerships are, I think, good opportunities, but I think we haven't seen them play out very well because there's, I think, maybe cultural issues with big pharma and, sort of scrappy digital health startups. In my mind, actually, maybe the partnerships that are the most beneficial are scrappy digital health startup and scrappy, small pharma, like, driving something, right? Like, that partnership, I think, is maybe a better fit. That's where I've seen more success stories. And I'm more than just Cognoa, just so you know. I do hot yoga too.
Well, this has been a great conversation. We're coming to the end. I guess my final thought or if anybody has a final thought, would be I don't see a lot of effort going into educating patients about artificial intelligence. And I think that is a big mistake for all the reasons that have been mentioned over the last hour. And I would just say that
that's a great
I think
topic for our next office hour.
I just think that's the responsibility of everybody in the health profession, let alone specialty societies. And I just think they've dropped the ball. So maybe we can talk about that next time. But in the meantime, thanks again, Brandon, and everybody else who's contributed. Have fun with the latest large language model, and we'll see you next time.